This is a video in clinical medicine from the New England Journal of Medicine.
Cricothyroidotomy is an emergent procedure performed on patients experiencing severe respiratory distress in whom orotracheal or nasotracheal intubation has failed. The procedure involves making an incision in the cricothyroid membrane, which lies between the thyroid and cricoid cartilages, followed by inserting a tracheostomy tube, which allows ventilation. This video describes how to perform a cricothyroidotomy in an adult. The major indication for cricothyroidotomy is the inability to establish an airway by orotracheal or nasotracheal intubation. Failure to secure an orotracheal or nasotracheal airway may be due to factors such as difficult patient anatomy, excessive blood in the mouth or nose, massive facial trauma, or airway obstruction due to angioedema, trauma, or burns, or a foreign body obstructing the airway. Whenever possible, cricothyroidotomy should be performed by physicians fully trained and skilled in carrying out the procedure. For example, emergency physicians, surgeons, and intensivists. This video is intended as a teaching tool for those learning the procedure. A cricothyroidotomy performed under emergency conditions can be left in place for up to 72 hours. If a surgical airway is still necessary after 72 hours, the cricothyroidotomy should be converted to a tracheostomy. While tracheostomy is preferred for long-term management, it should be performed in the controlled setting of the operating room. In urgent situations, cricothyroidotomy should be performed. This video will demonstrate surgical cricothyroidotomy, which involves placement of a tracheostomy tube through an incision in the cricothyroid membrane. In needle cricothyroidotomy, a catheter is placed over a needle into the cricothyroid membrane, allowing ventilation by a pressurized stream of oxygen. Because the catheter has a smaller diameter, it is less effective in providing adequate ventilation and should only be used as a temporizing measure while preparation is made for surgical cricothyroidotomy or tracheostomy. Needle cricothyroidotomy is the preferred method of establishing an emergency airway in children younger than 10 to 12 years, since the larynx is more easily damaged by surgical cricothyroidotomy in this age group. Cricothyroidotomy should not be performed when there is massive trauma to the larynx or cricoid cartilage, or when orotracheal and nasotracheal intubation are viable options but have not yet been attempted. Since this is an urgently performed emergency procedure, there may not be time to obtain informed consent, or the patient may not be able to provide consent. Cricothyroidotomy should be performed emergently even in the absence of informed consent. For sterilization and local anesthesia, the following are needed: gloves, protective gown and face shield, chlorhexidine or betadine, gauze pads, 1 or 2% lidocaine with epinephrine, and a 6 cc syringe with a 25 gauge needle. To perform the procedure, the following are needed: a tracheostomy tube, a scalpel with a number 10 or 11 blade, a curved hemostat, a trousseau dilator, a tracheal hook, a 10 cc syringe, and suture or tying material. A 6 mm internal diameter tracheostomy tube should be used. The tube should be no larger than 7 mm in internal diameter. A larger tube would be difficult to insert into the cricothyroid membrane. The tracheostomy tube is comprised of 3 parts. The outer cannula has a neck plate extending from the sides that allows the tube to be secured to the neck with sutures or a cloth tie. The inner cannula has an adapter at the end that attaches to a bag valve device or mechanical ventilator. The obturator provides a smooth surface to guide insertion of the tube. Though a 6 mm endotracheal tube can be used as an alternative to the tracheostomy tube, it is much less preferable because it is more difficult to secure to the patient's neck. Certain devices or endotracheal tube holders may be used to help secure an endotracheal tube to the neck. Place the patient in the supine position. Since this procedure is performed in extremely urgent circumstances, there is not time to drape the patient. Chlorhexidine or betadine should be applied if time permits. If the patient is awake, administer local anesthesia. In this video, cricothyroidotomy will be demonstrated on a cadaver to illustrate pertinent landmarks clearly. Directions are given for a right-handed operator. Site-specific designations should be reversed for left-handed operators. To perform cricothyroidotomy, stand on the patient's right side. Stabilize the larynx with your left thumb and middle finger, and use your index finger to palpate the thyroid cartilage. Move your index finger down until you palpate the cricoid cartilage. The space between the thyroid and cricoid cartilages is the cricothyroid membrane. This is where you will make the incision. Use the scalpel to make a 2.5 cm vertical incision through the skin and subcutaneous tissue. Use the curved hemostat to make a blunt dissection into the subcutaneous tissue. The initial incision should be vertical. First, because a vertical incision will avoid injury to the recurrent laryngeal nerves, which run parallel to the trachea. And second, because an initial incision above or below the cricothyroid membrane, if vertical, will allow extension of the incision as needed. In contrast, starting with a horizontal incision that is too low or too high would necessitate a completely new incision in the correct location. Next, use the scalpel to make a horizontal incision through the cricothyroid membrane. You may feel a pop as you enter the trachea. Extend the incision laterally, turn the blade, and extend it in the opposite direction. To avoid penetrating too deeply and perforating the esophagus, which lies posterior to the trachea, do not go more than 1.3 centimeters deep. To minimize the risk of esophageal perforation, hold the scalpel between your thumb and index finger and allow your middle finger to extend down the side of the scalpel, leaving the distal 1.3 centimeters of the blade exposed. If the patient is trying to breathe, once you enter the trachea, airflow should be audible and may also be visible. Once the trachea has been entered, make sure the blade stays within the incision so that communication with the trachea is never lost. Insert a tracheal hook and pull upwards on the distal portion of the incision, elevating the larynx. Once the tracheal hook is in place, you may remove the blade. Insert a trousseau dilator and open the membrane vertically. Then insert the tracheostomy tube. Hold the cannula in place and remove the obturator and attach the adapter. Inflate the cuff with a 10 cc syringe. Attach a bag valve unit and ventilate the patient. Look for symmetric chest rise and auscultate for symmetric breath sounds. Tie or suture the tracheostomy tube in place. Dispose of needles and sharps in the appropriate containers. There are three major complications of cricothyroidotomy. First, esophageal perforation occurs when the blade penetrates too deeply. To prevent this, allow only the distal 1.3 centimeters of the blade to enter the trachea. Second, subcutaneous emphysema may occur if the horizontal incision is too wide, allowing air to become trapped in the subcutaneous tissue. Third, excessive bleeding or hemorrhage may occur if a vessel is ruptured. If minor vessels are injured, the bleeding can be controlled with direct pressure. If major vessels, such as the carotid artery or internal jugular vein, are ruptured, ligation may be required. After the procedure, obtain a chest X-ray film to confirm placement of the tracheostomy tube. Call for respiratory therapy so the patient can be mechanically ventilated. Obtain a surgical consult so that definitive tracheostomy can be performed. An emergent cricothyroidotomy can be left in place for up to 72 hours.